Good morning, ladies and gentlemen. Good afternoon, good evening, depending on where you are. I'm Andres de Francisco, and I'm the director of the Department for the Family Life Course and Promotion of Health of the Pan American Health Organization. And I wanted to give you a warm greeting to this seminar on lack of data, lack of care. For decades, of the Perinatal Information System in Latin America and the Caribbean. It's an honor for me to be part of this fifth seminar celebrating the 50th anniversary of the Latin American Perinatology Center, known as the CLAP. First of all, let me welcome the Honorable Minister of Health of the Republic of Uruguay, Dr. Daniel Salinas. Dr. Salinas, we are very happy that you are with us now. We know that you have a very busy agenda, so we thank you for having prioritized this seminar. I also wanted to welcome Dr. Giovanni Escalante, representative of PAHO WHO in Uruguay, Dr. Susan Saruya, director of the Latin American Center for Perinatology, and dear colleagues, I especially want to thank the top level speakers that are with us today. This web seminar is part of the series celebrating the 50th anniversary of CLAPM under PAHO, a center that has continually collaborated for the perinatal and maternal health in the Americas. The objectives of this seminar is to disseminate the progress made in the use of SIP, the Perinatal Information System in the region, and to present its future developments. The speakers will approach the national and regional programs on neonatal, maternal, and sexual and reproductive health, as well as the future development of SIP in its plus version. Starting in the 70s, Club made several attempts to develop a perinatal form that would serve to collect, to gather information during pregnancy. But it was, then SIP was created in 26 countries in the region. The basic medical record became the standard roadmap for the perinatal care, gathering critical information, evidence-based data of each pregnant woman from the first antenatal visit until the mother's and the baby's discharge. The key characteristics of this topic are the following. First of all, it's a roadmap so that provider may give high quality care and take notice of the key signs and symptoms that serve as a warning. SIPR strengthens the capability of self-evaluation through the analysis of the institution when the capacities of analysis need to be developed. SIP has automated analytical tools that make it easier for the local centers. And it also provides all the cares a very nimble tool and user-friendly for operational research. Third, it's software. It's open source and free of charge and has been developed as a state-of-the-art technology for the point of care to analyze and file statistical information at all the levels of healthcare. For decades, CLAP has updated the contents of SIP to the best evidence available, providing standards and technological tools to ease the care at all levels, from the community hospitals to the centers of reference. SIP Plus is web-based, and it gets easily integrated into any data source with and with interoperability with all the other systems in the health sector. SIP Plus has been designed to add additional forms to cover the needs of the individuals in the course of their lifetime. The time has come to use real-time data collected from the individual health records to get to know the burden of our problems and the outcomes, the output of our healthcare services. There's more to come, and the future challenges will enable us to make the most of the modern I, uh, information technologies to increase the interoperability, in addition to artificial intelligence, and to produce reports to monitor new areas of care and for the usage of the country. So let's celebrate the 50th anniversary of CLAP. It will give us an opportunity to thank you all from all the countries in the region that have collectively contributed to this unique global experience, offering a standard point of care digital tool to improve the perinatal and the women's care. So thank you. With these words, I wanted to reiterate my welcome. And now I'll give the floor to the Minister, Daniel Salinas, so that he can tell us about SIP in Uruguay. And once again, we repeat that we are very grateful that you are with us. So, Dr. Salinas, you have the floor. Good morning. Good morning, everyone. We want to greet Dr. Andres de Francisco, family doctor, promotion of the family promotion of health and course cycle of PAHO, Dr. Susana Saruya, director of the club, and all the Latin American and Caribbean authorities that are participating at this meeting. Uruguay has, for 50 years, has hosted CLAP, and we have the privilege of having been able to contribute to the technical presence of excellence in the region. The original creators that joined Dr. Roberto Caldeiro Barcia created an area of science, ethics, and commitment that we are proud of. The pandemic made our work more complicated, but not neglecting the achievements that we've had in this matter in the maternal and perinatal health. To move forward, we need to focus on effective and due interventions. With no data, there's no care. And in this government in particular, we have especially highlighted the transparency of information, and that is why we need the data to provide an adequate and timely and trustworthy information. The Ministry of Health, together with CLAP, implemented SIP, the Perinatal Information System, in 1990 at the Clínicas Hospital de Clínicas, the University Hospital, at the Pereira Rosell, the Children's Hospital, and in a hospital in Paysandú. So, and then it was implemented in the rest of the maternities. So, completing SIP for 10 years has been a goal in Uruguay. We have an integrated healthcare system that is paid withholding money from the workers. That is, it's a per capita system through the FONASA system. And in addition, there's an additional percentage that is added based on goal achievement. In that respect, completing the filling in the SIP is a goal in the system to give a right to receive that payment. Each child that is born in Uruguay gets registered at the Ministry of Health and acquires a civil ID number that makes it possible to relate the information of that individual through different stages along the lifetime. This provides a transgenerational follow up and it makes it possible to have a regular analysis of the vital statistics of the population. We believe that this new version of the Perinatal Information System that has already been integrated to our live birth certificate, we hope that it will be related to the rest of the records that are generated along an individual's lifetime. So the proper links have to be established between the information systems. Uruguay is a leader, is one of the leaders at least in the digital world. We have a significant software industry and quite disseminated electronic medical record, and we especially wanted to acknowledge the work done by CLAP that pioneered this work. And for 30 years, they have been keeping record of the data of the pregnant women and newborns. So we want to make the most of artificial intelligence and the digital revolution for the benefit of people's health, as well as the big data that, if it's properly used, is a tool that makes it possible to provide analysis of population profiles and possibilities for improvement. We are committed as a government to make a responsible use of resources and to provide a greater accessibility of citizens to services. For Uruguay, there's no doubt that the Latin American Perinatology Center is a milestone in our country, and we want it to be a lighthouse, a beacon illuminating the development of medicine in Latin America and the Caribbean. So thank you, Dr. Andres de Francisco. Thank you, Doctor. We now give the floor to Dr. Suzanne Saruya. Thank you, Andres. Thank you, Minister. Thank you for your words. I believe it's a great joy and an honor to have you in our center and in this very special celebration of the 50th anniversary of CLAP. From CLAP, we have we are very happy to be in Montevideo, to be in Uruguay, and having this very peculiar origin with our founder, Professor Roberto Caldeiro Barcia. And we are aware of the commitment of your ministry and the government with the improvement of the health of women, newborns, and children. So the use of SIP from the moment of birth to the moment that the child goes to an adult hospital is something that we succeeded in doing together. So thank you for your support and your time. And in the behalf of the CLAP group, I tell you that it's been an honor to have you this morning. Now let's introduce the lecturers that are going to be with us today. Well, I'm the as was said, I'm the director of the Latin American Center for Perinatology and the head of the unit of women's and reproductive health. Today we have several lecturers and we are going to start with two speakers of the countries that use SIP. The first is Saida Mohammed. Zaida is going to speak to us from Trinidad to Tobago. That is a country that um, uh, has implemented SIP, and she's the biostatistician that works on a human and reproductive sexual health. She's an epidemiologist with a broad experience in the biologic methods and assessment of risk, maternal and child health. So Sada is going to tell us about the experience of the implementation of the Perinatal Information System in her country. Second, we have Padmini. Padmini Singh is a PAHO consultant in Guyana. She works in in the Department for Maternal Mortality Reduction. She's a medical doctor. She graduated in Cuba and she has a master's degree in Cleveland, and she has worked in the hospitals of her hospital. But Mini has honored us with her presence in CLAP in 2018. So now I'll give the floor first to Patmini and then to Sada to listen to the experience of those two countries, Guyana and Trinidad Tobago. So thank you, and go ahead, Patmini.
Good morning, everyone. Can you see my screen?
Unmuted, right?
Yeah, I'm unmuted. Hello?
Yes, go ahead.
Okay, good morning, everyone. So thank you, Dr. Suzanne. I'll be presenting a little system in Guyana. So just to give a little introduction, Guyana is located in the northeastern coast of South America. It is the only English-speaking country in the continent. We are neighbors with Venezuela, Brazil, and Suriname. Our population is not very big. It's less than 1 million, approximately 700,000 people. And we have a crude birth rate of approximately 19 per 1,000 population. As you can see in the picture there, the majority of our population is in the coastal regions. So we do have the disadvantages of having people in the hinterland regions where we do have a little issue there. So SIP, in May 2008, Guyana initiated the use of SIP. We were using the hard copy of the charts both at the hospital and the health centers. Perinatal manuals were printed to guide the correct filling of each field of the SIP form. By the end of 2008, we had approximately 80% of implementation in the country, and this was in the form of the new perinatal charts for take-home and the hospital use. The perinatal system provided a continuous flow of information from the health center to the hospital and back to the health center. By March 2009, all health facilities were using the SIP, both the hospitals and health centers, and this included the private hospitals as well. But at this point in time, we are only using the paper-based format. So as Dr. Suzanne mentioned, in 2018, due to the high maternal mortality ratio in Guyana, the Ministry of Health requested the assistance of PAHO WHO CLAP to assist with the transition of SIP from the paper-based format to SIP, the electronic version, as an intervention to help to improve antenatal data collection and analysis. A study tour was conducted in Uruguay in 2018, where a team of Ministry of Health staff, as well as PAHO staff, visited the CLAP. Resulting from this visit, when the team returned to Guyana, we facilitated an initial sensitization and SIP Plus to maternal child health workers in all 10 regions of the country. And the Ministry of Health added the collaboration of the IDB to help fund the implementation of SIP Plus in 3 regions of the country, from which this information system will eventually be scaled up to all the regions in the country. In 2019, the first pilot analysis study on maternal near miss was carried out at Guyana's National Referral Hospital, the Georgetown Public Hospital Corporation. The impact of this study was so great on the quality of patients' care that the Ministry of Health requested PAHO's assistance to carry out similar studies in 3 other regional hospitals in Guyana. Since then, a maternal near miss poster was created, as you can see reflected there on the right. And this was circulated to all health facilities with antenatal services, and initial sensitization on this topic was done across the regions of the country as well. In 2020, we did a needs assessment for the 3 proposed sites in the country and to suit Guyana's context, and it was handed over to the Ministry of Health IT department, where it is currently being adapted for use in Guyana. So some of the strengths for the implementation of electronic SIP Plus in Guyana, we have that there's familiarity of the paper-based charts which already exist, so the transition should be fluid. Data could be entered offline and uploaded when internet is available, and we do have a little issue with internet in Guyana. It's not standardized across the country. There are some areas that we have difficulties with, whereas there are some areas that we have better connection. Commitment of the Ministry of Health to this process. We have had the backing of the ministry throughout this whole process. Medical responsibility of what is documented, and it offers a standardized data collection method. Opportunities for the implementation of SIP Plus, we have that it is building a new culture to teach value of electronic data collection. This is something that Guyana needs to move into. We would learn best practices from other Caribbean and Latin American countries, as we did from Uruguay. SIP Plus forms are available not only for antenatal data, but includes various options. For example, abortion, SIP-A, maternal near miss, and also in this time of COVID-19, there's also a form that's provided for that. Utilization of data for decision-making and clinical care of patient and subsequent visits. Enhanced public-private partnership on data collection and transfer, supervise the quality of data, thereby improving the monitoring evaluation system, and also it would help us to collect standardized information at the different sites of implementation. So some of the obstacles that we had encountered for the implementation of the electronic version would include lack of trained personnel, limited human resources. We have limited clinicians' knowledge of SIP Plus, example for the generation of reports, etc. IT infrastructure to support this electronic version we still have some issues there, and the need for reliable internet service to be made available. So this is in a nutshell what Guyana has done so far from 2008 at the start of implementation to where we are now in 2020. And as we move forward to go into 2021, we hope that we would be able to have SIP Plus implemented in Guyana, and from there we would be able to improve the information, the medical information services. This brings me to the end of my presentation. Thank you very much, and congratulations to CLAP on the 50th anniversary.
Good morning, everyone. Thank you, Dr. Saruya, for the introduction. My name is Zada Mohammed, and I'm from the Directorate of Women's Health in the Ministry of Health in Trinidad and Tobago. And today I'm going to share Trinidad and Tobago's experience with implementing SIP and how the wealth of data that SIP collects has been used to improve maternal and perinatal care in Trinidad and Tobago. So why did Trinidad and Tobago want to implement SIP? Trinidad and Tobago is a twin island state with a population of about 1.4 million people, and we have approximately 16,000 births per year. Over the period 2010 to 2015, we were experiencing high maternal mortality. In 2010, we were about 71 maternal deaths per 100,000 live births, and this was fairly consistent over the period, with us being at 68 maternal deaths per 100,000 live births in 2015. We had no perinatal information system at the time, and the government was concerned about the country not achieving the MDGs, so they appointed a committee to review maternity services in Trinidad and Tobago. One recommendation of this committee was the implementation of a national electronic obstetric record to ensure the provision of a minimum level of care. Trinidad and Tobago was first introduced to the SIP in October 2015 when we participated in the first Caribbean SIP meeting. Having recognized the benefits that would be gained from SIP implementation, the Ministry of Health engaged PAHO and CLAP to begin training of healthcare workers and IT and record staff, and we worked with CLAP to develop a version of SIP that was tailored to our needs. We then piloted the SIP Trinidad and Tobago version for a little bit over a year, within which there was ongoing feedback on how to improve the Trinidad and Tobago version of SIP. Upon completion of the pilot in July 2018, we moved towards national implementation. So this is ongoing and is being done in a three-phase process. The first phase is ensuring that all public health facilities are using the SIP PCR. The second phase is ensuring that the Ministry of Health has the capacity to assess all the SIP databases from different regional health authorities in the country and can generate national data. And the third phase is having SIP Plus and the mobile application version of SIP in all public health facilities. The vision is that the data in each regional health authority will flow from primary care to secondary care and from the regional health authority to the Ministry of Health. So for phase one, the Ministry of Health issued a mandate to all public health facilities to replace the existing antenatal record with the SIP form. PAHO also supported the adoption of SIP by providing computer terminals to health facilities for data entry and printing over 40,000 SIP forms. Phase two, we recognized that there were deficiencies in the Ministry of Health that would have hindered the ministry's ability to effectively manage SIP data. We needed an additional server of data computer terminals for SIP use only and more bandwidth. And with PAHO's support, we were able to obtain a server that was separate and apart from the Ministry of Health's infrastructure in its own server room. And we were able to create a secure cloud-based network for all SIP records throughout Trinidad and Tobago. Transition to SIP, however, did not come without its challenges. And as we are still in the implementation phase, we continue to encounter some challenges, but we are working to address them. While the mandate for SIP using SIP has been issued, some providers still continue to use the old form, and those who use the SIP form often do not fill it out completely, especially in the case of the hard copy form. In Trinidad and Tobago, healthcare service delivery has devolved to 5 regional health authorities who are autonomous in their operations, and this can result in variances in service delivery. So we have found that the RHAs are at different levels of implementation. Specifically, the RHAs with smaller catchment populations, such as the Eastern Regional Health Authority and the Tobago Regional Health Authority, were able to progress to implementing SIP Plus more quickly than the other RHAs. And within the RHAs, primary care and secondary and tertiary care are at different levels of implementation. As Padmini would have mentioned, with SIP Plus, there are some IT issues that we ourselves have encountered, and we are working with PAHO to address those. And in the context of missing data and missing care, in Trinidad and Tobago, about 9% or roughly 1,500 births occur in the private health sector. The majority of the private health facilities currently do not use SIP, so we have no data on these babies, their mothers, and the quality of care that they receive. We have made progress, however, and this is because we have gotten the majority of the health sector to recognize the importance of SIP. We have given them a tool and have empowered them to assess the quality of care they provide for themselves at their facility. We have a dedicated unit in the Ministry of Health to see the implementation process through and provide support to the regional health authorities when needed. We would not be here without support from PAHO and CLAP by way of technical assistance and infrastructural resources. And I think most importantly, we have a Minister of Health who has supported SIP implementation from the beginning of the process and advocates for SIP nationally and internationally. So now that we have transitioned from the old antenatal record, which you see on the left, to the SIP record on the right, what have we learned? So what I have here is the basic indicator report which you get from SIP. The Trinidad and Tobago has its own basic indicator report, which selects data based on indicators that were prioritized in our maternal and child health manual. This manual sets the standard for maternal and child health care in Trinidad and Tobago. Before SIP, we had no systems in place to provide this data, to assess the quality of care, to determine the effectiveness of our policies and programs, and for reporting to PAHO and WHO. This is data from one regional health authority that has approximately 4,000 births per year. And because we now have SIP, for the first time, we have readily accessible data on risk factors for high-risk pregnancy. Having this data has allowed us to prioritize the areas where policy development was needed to reduce maternal and perinatal morbidity and mortality. SIP has given us, for the first time, data on the prevalence of hypertension and diabetes in pregnancy, which indicated to the Directorate of Women's Health that local evidence-based clinical guidelines in these areas were needed to improve quality of care and maternal and neonatal outcomes. SIP has also allowed us to see that over 85% of pregnant women were presenting to antenatal care for the first time, much later in their pregnancies than the recommended first trimester. This resulted in the Directorate of Women's Health developing patient information materials on antenatal care visits, and even the Minister of Health making a public appeal to pregnant women to present at the recommended time in the first trimester. As we continue to implement SIP nationally, our next priority is to have all public health facilities using SIP Plus and the mobile app, which we hope will reduce the missing data as you can't advance into adding more information until you fill the required fields. Once that is in place, we also want to introduce other SIP modules, such as SIP New for all neonatal units and SIP COVID-19. And finally, because SIP collects a wealth of information and eliminates the need for multiple data collection systems, we want to explore using SIP outside of the pregnancy setting, for example, for preconception care. SIP has actually generated a lot of interest from other government ministries in Trinidad and Tobago. And in fact, the Office of the Prime Minister has approached PAHO and CLAP to develop a gender-based violence health information management system, integrate with SIP for Trinidad and Tobago. In closing, I'd just like to say that implementing SIP has afforded us access to data on mothers and babies that we were never able to capture before in a readily accessible way. Though implementation is ongoing, what we have been able to analyze thus far has already led to improvements in maternal and perinatal care in Trinidad and Tobago. Thank you.
Thank you very much, Palmini. Thank you very much, Sayada. Two brilliant presentations. We saw from Guyana the great experience that the country has in the use of SIP, and now a decision to migrate to SIP Plus using the whole web-based, and thus having support for decision making. What we saw in Trinidad and Tobago always moves us in CLAP. 5 years ago, the minister was personally present in a meeting and made a decision at the highest political level that the country would have SIP throughout. He had an important reason, maternal mortality, the indication that they needed data that was quick and reliable, and he started implementing it. The whole country uses it for decision making, as has been shown. Automatic reports come out through an architecture of artificial intelligence, which allows those algorithms that we can quickly locate women who are at greatest risk, and challenges are continuous. It's true, we are now working, thinking of the future of Trinidad and Tobago. We shall surely take it to other countries, a whole evaluation of gender and violence against women. We are now finishing the times of political activisms for the elimination of violence against women. So thank you very much for both of you for your time, for celebrating with us the 50 years of CLAP and SIP. Okay, we go on with today's lecturers. The next lecturers are four people that are very well known in the region. We shall now have the experience of an integrated lecture with four of the CLAP advisors. The first one is, I know, very well known by all of you, Luis Mainero. Luis has been working for years in CLAP. He is a technology advisor, and he will tell you his experience from his vision on systems, showing you what we have and what will come.
After that, we'll have Pablo Duran, who's our regional advisor on perinatal health for PAHO. And Pablo will tell us the algorithms and how the AI algorithms help us. Then we'll listen to another regional advisors, Bremen de Musio, who will show you all you can do when you have excellent databases for many years. He'll show you a beautiful example of how we use that. I won't tell you more than that because he's going to scold me as a spoiler. And finally, we have Rodolfo Gomez Ponce de Leon, who's our regional sexual and reproductive health advisor, who will show us also another use of the platform and how it can be used for sexual and reproductive health. So now I leave you with Luis, Pablo, Bremen, and Rodolfo, and I hope that you may enjoy this presentation by CLAP.
El sistema informático SIP es un producto gratuito de OPS que registra la atención perinatal desde la primer visita antenatal hasta el alta de la madre con el recién nacido, contribuyendo a la toma de decisiones oportunas. La historia clínica se ingresa simultáneamente a una computadora o cualquier otro dispositivo móvil y se transmite online o de forma diferida con las máximas garantías de seguridad y privacidad. El SIP Plus puede vincularse con cualquier otro expediente electrónico que exista en la institución o en el país. El SIP Plus elabora reportes automáticos de indicadores de la población asistida y resultados perinatales, identificando brechas de inequidad que orientan la gestión de servicios. Cuanto mejor y más accesible sea
the use of services, the better and more accessible the information, the better the health will be. SIP Plus helps 22 countries to improve the health of mothers and newborns, but the best is yet to come. Luis, go ahead. I think that you can get started with your presentation. Well, good morning, everybody. Today, I'm going to tell you a bit about SIP Plus and the characteristics that define it. And as it's going to be a very quick presentation, I divided it into 4 parts. I'm going to show 4 short PowerPoints with the models and integration, the medical records, the analysis, and the reports available with SIP. And then what we'll see for the future for SIP. As we all know, the perinatal medical record with its different forms is loaded. It's entered in the centers that collect the medical data, and that is so the information is loaded in tablets, smartphones, Macs, notebooks, or any specific computers. The strategy behind this was to enable people to enter the information in real time from any of these devices. Hence, they create the small local databases, and this is different from the prior version of SIP because this enables the sending of information automated and synchronized way in a centralized server. And this is extremely important because different from what happens with other systems, SIP Plus makes it possible to synchronize the data and consolidate from the different devices and consolidate it at the ministries and locally or regionally, thus integrating it into other programs already existing at the ministry. For instance, the live birth certificate, the death certificate, vaccines, civil identification, course of life, and everything that is under the so-called e-health, e-salud. As to the medical records and the reports, SIP presents several models. It's a heavy software. It's big. So I'm going to divide it into 2. We're going to see the medical records and then we'll see the indicators reports. As to the medical records, we have the perinatal medical record that is the backbone of the system. But other forms have been added, including the CPAP forms for abortion, the and then another form for the newborns when they are admitted after childbirth, and other that we will add in the future. At the beginning of this pandemic, CLAP incorporated the SIP Plus, the maternal and neonatal COVID. We also incorporated in SIP Plus very innovative developments, including the community medical record, promoting its usage in some areas of difficult access or with low connectivity, as was mentioned earlier. This medical record was developed by CLAP based on the 10-year work to be used with mobile devices at a time where there was no software for these devices globally. So SIP Plus is not just a form where you load the medical records, but it's an integrated system in the maternal and child health. But very recently, CLAP has worked jointly with the Ministry of Health to listen to the suggestions for adapting the medical records depending on their needs. That gave rise to an adapted medical record for Argentina, for Bolivia, for Uruguay, for Nicaragua, for Colombia, and in the British Caribbean for Bahamas, Grenada, St. Kitts and Nevis, Trinidad, Tobago, and recently for St. Lucia. Now we'll see how in the second part, concerning the indicators, the first example of indicators is the basic statistics report that has been maintained throughout the years, and we decided to maintain it in the first versions of SIP Plus, and we made it available. But there are other reports that have been created, such as the elimination of vertical transmission of HIV, Chagas, and the Robson indicators that WHO uses to compare the cesarean section rates. And we are also contemplating the most modern models, such as deep learning, decision trees, or neural networks. So this has to do with the reports. But what happened? As we were requested to develop, to make small changes in the perinatal medical records, we also made small changes in the reports as requested by the ministries of health in of the countries. So Argentina, for instance, the Ministry of Health requested some specific things. Honduras, Bahamas, Nicaragua, Dominican Republic, Trinidad and Tobago, and Uruguay requested such changes. So, in addition to the regional models that SIP offers, in this presentation, we see how we gradually adapted the information system to the needs of the various countries. Very quickly, because we can't give you a demo of all SIP Plus in this presentation, I'm going to quickly show you how it works. I'm going to change from this screen and go to SIP Plus. This is the initial screen of SIP Plus. We have a server in CAP that's available for all of you. You may consult it at the end of the presentation. There's a user in Spanish that's called Invitado, and the password is SIP Invitado, and in English, the user is SIP E. So for the purpose of here, I'm going to use a user that we prepared for today. I put a user's name and password, and this is the initial screen, the home page. Here you can enter new forms and look for updated registers or to print or whatever you need to do with them. So I'm going to print on search to bring any medical record by chance. We prepared a database that does not reflect any center in the Americas. This is just for training purposes. So you bring a number of medical records. Here I put this Mariana on top. This is the medical record. And when I press on forms, we'll see how the various medical records that I mentioned earlier can be seen in SIP base. You have the basic medical record with the data of this patient, and we broke down the medical record into different modules to be filled in very easily. It's very easy to fill in this e-record. I'm going to click here with the mouse. I don't know whether you see it in the center of the screen. This is the way you click on it. If you have a touch screen just by touching the device, then that's it. Then we go through the different modules. SIP, as Suzanne was telling you in the previous presentation, has already included some brief concepts of intelligence, so as to speak. For instance, I'm going to put there the blood pressure. This woman, Mariana, 140-70 millimeters. And we're going to see how SIP Plus in the last row, I hope you can all see it, there's a red row, automatically is telling you that although the value of 140 in the blood pressure is okay, although it's valid, it might be a clinical alert. That's why they put it in red. So SIP has many of these options. And insofar as the countries and the institutions load it in real time, there's a sort of feedback with the healthcare team to make the proper and timely decisions. As I was telling you in the previous uh, part, there are other forms, and I'm going to show some randomly. Let me choose the basic SIP, but of Bolivia. You see that in the third and module is similar. This is the second module in Bolivia, and this is Bolivia, and these are adapted to the countries. The countries have made small suggestions, small changes. In the case of Bolivia, they have, for instance, they added the mother tongue, and you can put the different ethnic groups. That these are small adaptations, and there are other countries that have used them. The case of Argentina and Uruguay, they're similar. Argentina has a small difference in the HIV and syphilis model down here at the bottom, and the same applies to Uruguay. So these are very slight changes that CLAP is requested to modify the medical record so it will adapt to the country's needs. Nicaragua also made a recent change. And where are the English-speaking countries? Indeed, I am showing SIP in Spanish, but if I were to put it in English, automatically here I would see the medical records adapted to the different countries. For the sake of time, I'm only going to show Trinidad and Tobago. That was the first country to adapt it for the British Caribbean. I'm going to show it just for you to have a quick look. But as I said, SIP is not just entering the medical records. It's also a huge analysis drive. I put it in Spanish. There you have the reports, and in the reports part, in this sort of list, a drop-down list, here you have all the reports that we just mentioned. As an example, let me show you, for instance, the basic statistics, that this is a report that CLAP uses a lot with a brief summary. Please consider that this report was done immediately out of 15,000 records with live birth and data of the mother, childbirth, and a newborn at the end. So these are the basic statistic reports. But as you may see here, I won't show you, but I wanted to show you the part of the countries: Argentina, Bahamas, Honduras, Nicaragua. So I don't want to say, because I don't want any misunderstandings, that here you see the indicators of SIP Argentina, but no, you'll be able to see the information as Argentina sees it, based on the local data. So we are committed with the anonymous nature of the information and the safety, and that is included in the software. So going back to the search, I'm going to click on this so it won't get lost. And now I'll show you the other analysis that are descriptive analysis that are very, very easy to use, extremely easy, and depending on your knowledge, it has a huge power. So for the sake of today's demonstration, I show an example that everybody understands, for instance, maternal age. So let's take an analysis of maternal age. Here we have the global data. Here we have it by years. Here we have a graph, and here we have, for instance, a graph based on the years. For instance, with with adolescent pregnancy, you see how here it has been reduced with time. So this is what we have to show you of the current SIP. Now, how do we see the future of SIP? As I said earlier, we incorporate state-of-the-art technology, but also we continue to develop the software, including MISIP. MISIP is a device for smartphones that can be downloaded from the different internet platforms so that women may be closer to the health services, and in the future they'll be able to send queries for the medical records and questions, or just consult recommendations in the from and will make available an alert button that through by pressing that button you can send the GPS data location, or to call the healthcare professionals or some relatives. And this is the idea of MISIP, to take the woman closer to the healthcare centers. And the old perinatal information system that was, and the old card, health card, that Latin American and Caribbean women use may be replaced by this form to monitor them. So we want to stress the accessibility of all the devices, including tablets and smartphones. FLAP conducts a permanent updates based on the best evidence. It has interoperability with the available health systems. The information is in the web.
And why not? Something people are talking a lot about, guaranteeing equity and information for the health of the most vulnerable populations. This would be my presentation. I wish to thank each one of you on behalf of the SIP team and club, and particularly to acknowledge a very dear colleague and friend as Gerardo Martinez, and here's my humble homage to him. Thank you very much. No one is somebody, just one man, just one immortal man is every man. That's what it said there. Thank you very much. Thank you very much again. Good morning and good afternoon to all of you. And I join in thanking all of you for your participation in this seminar and this celebration. And along the same line of the colleagues that went before me, the idea is that in these few minutes, I could share with you a few reflections and some very special aspects regarding SIP as a strategic tool that we have seen. It is a solid tool strongly oriented towards the care from a strategic point of view, but in this case, from the perspective of newborn health. I would like to stop briefly in four aspects that summarize and reinforce what my colleagues mentioned about four aspects why we are convinced of the strength and the strategic value of SIP. One is the strong based on evidence, and evidence that is updated constantly, so that all that SIP contemplates in its different modules, and in my case, particularly the neonatal module, may provide all the people who are responsible for care at different levels, information, data, indicators that are based on the most updated evidence. And as Luis Mainero and other colleagues mentioned it, not only regarding general perinatal care, but at the times when special situations occurred, such as in 2015 and 16, the Zika epidemic, or right now the COVID-19 pandemic, SIP has included that new evidence. The second component is quality, oriented first of all, because from the point of view of CLAP, PAHO, and SIP, the center of care is focused on the newborn, woman, and family. It is to provide guidelines that may contribute to an optimal quality of care, but also from the point of view of decision makers, people who are responsible at the ministerial level, management of health services level, so that the care provided is of quality and SIP. And that's why it is in yellow, because in the clinical record, those situations that should alert care are in yellow. But not only individual care, but also from a public health perspective, SIP's strength in surveillance and monitoring, and of course, oriented towards providing quality care. And I would only like to mention one aspect, not because it's the only one, but because it's the newest. For instance, a week ago, we launched the Spanish version, and in the coming days, we shall have an English version of the clinical practice guidelines that are evidence-based for the follow-up of at-risk newborns. The evidence that has just been published already has specific indicators and automated outputs, as Luis Mainero mentioned, for the care and quality reports on quality of care. Condition at discharge, inequality analysis, for instance. That is an example of how, from PAHO and CLAP, in a comprehensive manner, we try to provide tools that relate clinical practice to the generation of evidence and information. And I will now share with you directly from SIP how these indicators, based on the reports that Ms. Pinedo mentioned, may immediately provide indicators. I will just concentrate on perinatal results, but this is relevant, obviously, for families and newborns, but also for those who are responsible for managing health services, subnational and national authorities, how to have data on conditions at birth, low birth weight at birth, distribution by gestational age, weight for gestational age, or vitality at birth. Or, as we said before, the importance from the public health of the analysis of inequalities, the possibility of having an output according to two stratifier here. One is single parent home or maternal education. The indicators that we just mentioned about birth weight, gestational age, or vitality. In this way, I wish to thank you for your attention, and I'll let my colleague Breben de Musio speak now. Thank you very much. Hello, how are you, dear colleagues? It is a pleasure for me to have the opportunity to share this time with you. And for this opportunity, I decided to speak about obstetric interventions with a review for the past 10 years of SIP in Uruguay, and that's why we are talking about the Uruguayan example of SIP. and especially wish to thank my colleague and friend, Professor Claudio Sosa. Many of the slides that you will see were made by him. In this presentation, the Minister of Health of Uruguay, Minister Salina, already mentioned some of these things, and so did Dr. Andrés de Francisco. But look at this. It's 37 years of a process of continuous building in Uruguay, unlike other countries in the regions that had times of great development of SIP. But Uruguay has been very constant with its public policy. It started, as Dr. Salina said, at university hospitals in Uruguay, but then it was incorporated till 1990, the Ministry of Health, through what used to be the Program of Maternal and Childhood Health, uh, passed a national directive for its use in the public and private institutions. And this is a great difference with many countries where private services do not use or are the only ones that use SIP. In this country, it is used both in public and private institutions. And at time when there was no integration comprehensive health system that only was created in 2005. And in 2008, that was included in the goals for the per capita payment for health services, both public and private. We said that in 2008, these goals appeared, and this is a key element in the country. Please look at this list, where you will see that in the 2009 coverage was of approximately almost 90%. It really rose in the country, and it has kept growing up to 2018. So from 2009 to 2018 coverage of SIP is almost similar to the one of live birth certificates. So SIP has a population coverage in Uruguay, and that is a key element for the analysis of its information. So I will focus on 5 interventions. I will talk more about C-sections and induction because they have the greatest weight, but we shall also see what has happened with active management, timely clamping, and episiotomy. If I show you this slide, which shows the trajectory of C-sections in Uruguay from 2009 to 2018, or induction, regarding C-sections, many of you have the evolution of C-sections in your countries, but the advantage of the Uruguayan government nowadays is that just by clicking a button, they can get this evolution of C-sections, where you see there has been an increase of 36% in the C-section rate in 2009 to 45%. In orange, not every country can get that line because induction is not a piece of data that is systematically collected in all countries. And please note that we are also seeing an increase because in 2009 it was 14.2% and it is now 19.6% in 2018. And we shall see that there is an association in this problem. Please note that the correlation is 0.87, very close to 1, so it's a good correlation in this relationship between C-sections and induction. In order to see these data, C-sections and induction, we use that output that Luis mentioned, the Robson indicators, that allow us to see not just C-sections, but also the results of all pregnancies according to 10 categories defined by Dr. Robson in England, in Ireland to be exact. And you will see that these are 10 categories that are absolutely exclusive among themselves, but complementary. And these are the ones here, but we shall focus on the first 5, where you can see that they are related to the ones that have the highest representation in the number of C-sections that are produced in a country. And why so? Because these 5 categories account for 80% of terminations of pregnancy in any country. Please note group 5, as you can see down here, all multiparous women with at least one uterine scar are subject to C-sections. That trend has not increased in Uruguay. It was around 18.5%, and it is 19 in 2018. It's a marginal increase. But note at the category in group 2, where you can see that we are talking about nulliparous women with induced deliveries and end in elective C-sections, and this group increased. And group 4, multiparous that are induced or subject to elective C-sections has also increased. This leads us to think, well, inductions increase, C-sections increase, but we decided to do multivariate analysis in order to avoid some biases and mainly some confounding variables. Please note that induction says that if you are going to induce delivery for finishing the pregnancy, at least in Uruguay, there are 3 times more chances that these women would end up in a C-section, just like women with previous C-sections, almost 3, and nulliparous women in particular have almost 3.5 times more chance to end in C-section than the rest of the population. Other groups, really, it seems that there are some protective factors. Please note adolescents, the chance is below 1, so there is a greater chance to end up in a delivery, the same in multiparous women with 3 or more previous births, but the chance increases in women above 34 years of age, where there is a body mass index higher than 30, and this is a pathology. Obesity is increasing in all our countries, and unfortunately, Uruguay is not outside of that reality in women with a certain pathology as well. What has happened in other evidence-based obstetric interventions? Let us look at the blue line. Episiotomy in images is being reduced. Please look that in 2009, before interventions that were specific from university hospitals and the Ministry of Health, but mainly from the departments at the university, routine episiotomy in primogenists has gone from 50 to 35%. That is good news. And it is also good news, the increase of the late clamping of the cord. You see that from 56, we have gone up to 91%. That also speaks well of evidence-based interventions and how they are applied in Uruguay. Let's look what happens to active management of this next step. Uruguay 2009 had 80% of patients subject to active management, and it is now almost 89%. There has been an increase, but it is below what we would like to see, because we would like to have it close to 100%. Where is the success of CIP in Uruguay? First of all, because it has been a state policy. When we were in 1990, the government of the time was a government of the Partido Nacional, National Party. The president then was the father of the president today. Between that presidency and the program, there was one by the Colorado Party, Frente Amplio government. So the whole political spectrum in Uruguay has maintained this. It has gone beyond different governments, and the common interest has gone before the interest of private companies. In other countries, we have seen private software companies that have substituted SIP without improving it. but every Uruguayan government has maintained the SIP, and they have made efforts also to improve it and make it compatible with private systems. But SIP remains the tool with which Uruguay measured its care goals. And another key element is the analysis of information, not that we do it from PAHO or the PAHO offices in Uruguay or, or any country. Of course, we can support them. Analysis is important if it is done by each country or countries to use that information, because through the use of our information, interventions that are based on them may be proposed as operational research and not to generate academic studies, but political policy interventions of projects and plans to be mobilized from the government or the institutions. To finish, I would like to show you this because it was a present today. Just today, please look at the date, December 9. This study has been published. We work together with colleagues from PAHO immunizations, but also the people of Emory University working in immunizations. Comersad is a very important author right now regarding immunizations, but particularly in maternal and perinatal immunizations. And he has a grant by Bill and Melinda Gates Foundation that is very large. And we worked on the Latin American SIP base with him because this study that was published today, where most data is from Uruguay, will serve as a basis for the introduction of the Streptococcus V vaccine in pregnant women. So please how important the use of information that lies in many countries, and unfortunately it's not always used. I am sorry if I took a minute longer, but I thought it was worth mentioning this. And thank you very much for this opportunity to the SIP colleagues and Suzanne for allowing me to make this presentation. I will now introduce my colleague Rodolfo Gomez Ponce de Leon, who's advisor in sexual and reproductive health of the Pan American Health Organization, and all that has to do with that area. Rodolfo. Thank you very much, Bremen. Thank you all for participating with us in this great celebration. I wish to share with you some brief ideas about some key points on sexual and reproductive health and how the Perinatal Information System has covered this need of the countries for a long time. To begin, and Luis mentioned it, I would only like to comment that there are 3,500 children born in a region born with HIV passed on from their mothers during pregnancy and delivery. 2,800 children are born with congenital syphilis. Of the new Chagas diseases, 20% are because of contagion from mother to child, and 6,000 children every year in our Latin America get a hepatitis B contagion.
That of the Ministries of Health, one of these important the elimination. It's not reduction, but elimination, that is to remove them from Earth. There are 20 countries in Latin America that are reporting the advances, and they had a very strong commitment to be able to eliminate them. Of the 15 million pregnant women in the region of these four diseases, having SIP enables us to quickly, with a click, to be able to analyze how close we are to eliminating these conditions, and especially these 20 countries that monitor this annually in the region. They can report the secretariat, that is PAHO, the degree of advance of progress, so as to learn from each other. We see that there are also impact indicators, uh, the presence of the disease during pregnancy, and there you see the data on childbirth, postpartum, and breastfeeding and the screening. So we see that there are indicators at the beginning, at the middle, and at the end of the process, and we have some related to family planning, whether the pregnancy was planned or not, whether they used any contraceptive methods and it failed, whether it was an unintentional pregnancy. These are some process indicators that the region has committed upon. Clicking on this ATME Plus automatically, you can have access to this in just seconds. Another indicator, another registry is SIP-A, or the Registry of Women Undergoing Abortion. So following the parameters, as we said, SIP is a marker of a standard of care and a roadmap. So by following this rationale based on the criteria of the World Health Organization, that enables us to put a standard of care. This medical record is registered and it's being used by many countries in the region. And it also has automatic indicators. These indicators basically have two groups. One in the countries where the legal interruption of pregnancy is allowed, so it's a legal termination. And in the other group, patients that receive care with a spontaneous miscarriage, and they go to the public hospital. So you have the two different possibilities, and that is why it's called women undergoing abortion, and it includes these two situations. We also have here a large database with women that may be analyzed with just one click and all a long time. This is a second report that makes it possible for us to analyze the morbid mortality of mothers, etc. And we have a regional database with over 100,000 registries or records contributed by the Sentinel centers that are registered in our region. So we had an experience analyzing the databases of these 16 countries in the region and their contribution to the network, to Club Musa network, and they contribute with data of their medical record, and they are sentinel centers that represent the maternity that the Ministry of Health in that country has appointed as being the sentinel of the reality in the country. So you can do sentinel monitoring of some activities. So we held a meeting of these sentinel centers, inviting 40 healthcare professionals from these centers to 14 mentors, 14 experts in the region that contributed as experts to the analysis of the databases of each of these hospitals. We have 24 proposals for research to analyze the data and 18 papers that were submitted at different stages of publication. So here we see, for instance, that we had this, they developed this technology that is called EMISIP, that is to make decisions based on evidence and evidence-based decision making. This experience was published, and precisely you have the description, the details of what was the methodology, the analysis of quality control of the data, data analysis based on SIP, and the contributions of the 14 experts. Some of the publications that appeared related to that in Chile, they showed the experience of how they modified care owing to the presence of this medical record in Brazil, in Campinas. They also showed how they increased the quality of post-abortion care, especially in terms of the contraception measures after the implementation of SIP-A. So this shows that not only is it a variable for record as a roadmap for that patient specifically, but also it also makes it possible to do a population analysis a long time and how the quality of services can be increased thanks to quality control, a continuing quality control. So let's leave the past and tell you about the future. I'm being very excited to tell you of some innovations that are currently underway and that are getting formed in this as we celebrate our 50th anniversary. One of the new medical records that we develop is that of contraception using the medical criteria of eligibility of the WHO. This will make it possible for us to use this round of criteria automatically, this wheel, as artificial intelligence, including the variables that we need to include to choose the method for that woman that smokes over 30 cigarettes, is an adolescent, had a pulmonary thromboembolism, etc., and to be able to use the ideal contraceptive method for that woman. But it will also enable us to use that information to analyze the quality of the services that we provide to a population, to see the unmet needs for contraception, to calculate the need for contraception methods, age, and risk factors that each of the hospitals and countries will need so that we can meet the unmet need, especially in most vulnerable populations. Another method that was already announced by my colleague from Trinidad Tobago and Dr. Saruya is precisely the development of SIP with a gender violence record. This was a special request by Trinidad Tobago that will be then used and adapted to the various regions in Latin America and the Caribbean. This is responding to the standards that the WHO has marked as a response of the Healthcare Center to gender violence. So the commitment to eliminate on the unmet needs for contraception in the that is discussed in the SDGs, and especially after Nairobi conference, and the elimination of gender-based violence will also have a technical element for evaluation, implementation, and monitoring. So this is the future of SIP as a medical record, and it will migrate, giving us a possibility to facilitate the contact between the healthcare providers and the woman, the users, through MiSIP. So we'll be able to use elements, family planning, and contact among the healthcare providers, both in the contraception medical record and the gender-based violence. So we see a new path that gets opened that will make us thrive. So as a conclusion, SIP is a roadmap for the quality of care. In addition, SIP protects many rights, including the right to life, health, and the quality of care, to receive the highest quality of care available. SIPA defends, protects, and monitor the practice of many sexual and reproductive rights. So it's a tool that has proven to be useful, and it has proven its a great potential. And with this, I finish my presentation. I thank you. And I have the great honor of introducing our dear colleague, Jose Luis Pato Diaz Roseño, who does not have a part-time contract with CLAP. He has a lifetime contract. He has devoted his life to this institution, and it's a great joy for me to introduce him. Pato, the word is yours. The floor is yours. Hello, everyone. This seminar that we are completing is the product of cooperation between CLAP and hundreds, thousands of professionals of Latin America and the Caribbean that have contributed to develop, implement, and improve SIG for almost 4 decades. This year, unfortunately, we lost Gerardo Martinez, who led the last two versions of SIP and Isamiam, and he completed SIP+. Gerardo was an example of technical cooperation with the countries. I had the privilege of participating as a pediatrician and as a CLAP professional since 1975 decades, and I worked with many colleagues in the staff, especially with Gerardo. It was in the last 30 years. So remembering Gerardo in the testimonies that we'll see in a video will be paying tribute to all those who participated and participate in the collective development of SIP. It's it's a good recognition for all, as Gerardo would have liked it to be. This video is also the big embrace in cooperation between CLAP and the countries for the better care of those that most need it. So my embrace to all of you and the warmest remembrance to Gerardo Martinez.
Gerardo Martínez ha sido en CLAP
Gerardo Martinez in CLAP has
de la
been
correcta información para se
the
tomar
advocate of the
la
correct
mejor
information
decisión política.
to enable us to
Gerardo ha
adopt
trabajado
the
en
best
muchos
political
países
decisions.
con
Gerardo worked in
enorme
many
dedicación.
countries with a huge dedication.
Muchos de esos países
Many of those countries
hasta el momento lo
so
identifican
far
como
identify
el
him
SIP, Gerardo
as
del
SIP.
CLAP, Gerardo del
Gerardo
CLAP.
equals
Y es una
SIP,
alegría que
Gerardo
sepamos que
from
un
CLAP.
compañero
And it's a
ha
matter of
logrado
joy for
contribuir
us to
en la
know
región
that
de
this
manera
colleague has
tan
contributed
importante.
in the region so
Me resulta muy difícil
importantly.
hablar de Gerardo solamente un
It's
minuto,
very difficult for
así
me
que
to
voy a omitir
speak,
toda la parte
to
laboral,
limit
lo gran
myself to
profesional
just
que
1
era,
minute
lo bien que sabía
speaking
hacer
of
su trabajo, porque
Gerardo.
eso en toda América todo el mundo lo
Let
sabe,
me highlight
y
that
la
he
difusión que ha
did a
tenido el
wonderful
SIP
job.
en gran parte
Everybody
se
is
la
aware
debemos
of that in the Americas,
a
and
su
the
aporte.
dissemination of SIP
Me gustaría más
we owe it to
centrarme en su
him.
calidad humana,
I'd
como
like
la
to
gran persona
focus
que era.
on him as a
Trabajé con
person,
él
the
durante
beautiful
casi
person
30
he
años,
was.
siento que puedo decir,
Working
como
with
decimos acá
him
en
for
Uruguay,
almost 30
que era un gran
years,
tipo. Compartí
he was
oficina
a
incluso los
great
últimos 5
guy.
años y
I shared
sentarse
the
a
office in
conversar
the
con
last
Gerardo de
5
cualquier
years,
tema o plantear un
and
problema laboral o incluso
talking
personal,
with
siempre
Gerardo with any
encontraba su consejo
topics,
preciso,
I
la palabra
always
justa, y uno se iba
found
haciendo
the
mejor persona de
precise
lo que era antes de
word
conversar con él.
and
¿Qué más
when
puedo
you
decir de Gerardo? Que lo extraño. Todos los
finished
días lo extraño.
talking to
Nos dio
him, you
mucho a
felt
todos quienes
better.
compartimos
I
con
miss
él,
him every day.
pero sin
He
duda
gave us
tenía
a
todavía
lot,
mucho más
all
para
of
dar.
us who shared
Gracias,
something,
Martínez.
but there's no doubt
Lo
that he
recuerdo
had
como
a lot
un
to
gran
give.
compañero,
Thank you, Martinez.
un gran amigo.
I remember him as a
Y
great friend,
él
a
era
great colleague.
tremendamente
He was
bondadoso con su conocimiento. Gerardo ha
extremely
alcanzado a
generous
sacar
with
el
his
tema para que
knowledge.
estuviéramos hablando un buen rato
Gerardo
sobre eso. No se quedaba con la parte más
was
superficial,
always
le
ready to
gustaba ir
go
más a lo
deep into
profundo.
the topics, never shallow.
Y,
He
y
liked to
bueno,
go to the deepest things. And
obviamente el SIP no hubiera
obviously,
sido posible sin
SIP
él.
wouldn't have
Hay
been
muchas
possible
personas
without him. There are many
que
people
colaboraron con el SIP,
that
muchas,
collaborated with SIP,
pero definitivamente hay algunas
many,
pocas con las que si
but
no hubieran estado,
there are
el SIP no hubiera sido
very
posible.
few
Y Gerardo es una de ellas.
without whom
Creo que
SIP
es un
wouldn't have been
compañero que lo
possible,
extrañamos
and
todos.
SIP is
Creo que es un
and
compañero que no pasaba desapercibido en el
Gerardo is
club
one
por
of
su
them.
forma de ser, por su
He
compromiso
never
con la
went
gente del club,
unnoticed
con los
because of the
compañeros del
way
club
he was, his
y con los
commitment with
colegas
the
también de los
people of
países.
CLAP and
Lo
with the
recuerdo como
colleagues of the
un
countries.
gran
I
compañero,
remember him
un gran
as a
amigo
great friend, a great colleague,
y todos en club lo
and
extrañamos muchísimo. Todos,
everybody at
sin lugar a
CLAP
dudas.
miss him. Everybody,
Aquí en
no
nuestro
doubt.
país
Here in our country,
lo recordamos con mucho respeto,
we remember him
con quien entre
with a
otras
great
cosas
respect.
aprendimos a aplicar el
Among
concepto de
other
medicina
things,
basada en
we
evidencia
learned to
aún
apply
antes
the
de que
concept
esto
of
fuera
evidence-based
implementado
medicine
internacionalmente.
before
Aquí
it was
todavía
implemented
implementamos
internationally, and we still
las
implement
cosas que aprendimos con él en
the
nuestro
things
trabajo
that we
diario.
learned with him in this
Creo
work.
que fue su humildad,
I
la humildad que
think that
tenía para
his
enseñar, para
humbleness,
transmitir los
his humbleness
conocimientos
in
y que
teaching, in
también hacía lazos de
transmitting
amistad.
knowledge, and
En
also
Centroamérica no hay un solo país
the
en donde no
friendship. In
haya
Central
dejado
America,
un
there are
grupo de
no countries
personas
absolutely
que
where
lo
he hasn't
recuerdan con mucho cariño,
let
con mucho respeto y
left
que en ese
a group of
desarrollo del sistema
people
informático
remembering him
perinatal, en
with
esa
warmth and with
institucionalización
respect.
del
And
SIP, también se establecieron lazos de amistad. Así que, ¿qué puedo más decir el día de hoy en tan poco tiempo? Solo decir lo que fue un amigo extraordinario, que lo quiero mucho en vida, lo quise mucho, pero aún lo recuerdo, lo llevo siempre en mis pensamientos y estoy segura que muchas otras más personas en toda la región que trabajaron con él estarán sintiendo lo mismo que yo.
thank you, Pato. Now we are about to finish. It's difficult to put an end to this after this tribute. This is the fifth webinar celebrating the 50th anniversary of CLAP, the 5 decades that we have worked for more health for women and children. Of course, this would have been impossible to put an end to this without paying tribute to Gerardo and to his family. I wanted to tell Mari, Sofia, Micaela, and Mayra that we remember Gerardo and thank Gerardo every day. It's been 38 years at CLAP. So if that contribution, his contribution was huge, and I'm sure that his absence at home was also.
I would like now to thank especially also the people who made the presentations today. This is the only webinar where we have had our club colleagues presenting, and they were brilliant. Of course, as usual, they took a bit longer with their own personal styles, and they were brilliant. But I also want to tell you that we had the honor, the joy to have the Minister of Health of Uruguay, who is a partner of CLAP. CLAP and the ministry have had an agreement for 50 years, and that is why we are in Uruguay. The country that the founder of CLAP is Uruguayan. It's an honor to be in Uruguay, and I really wanted to thank for the presence of the minister. Also, our two participants from the countries, Padmini and Zada, who have shown the examples of two countries that are so important in the region. I could not finish without thanking the team that is backstage working for these seminars, these webinars to take place. We have the translators, the team that does all the connection and transmission, and the leadership of our journalist, Ana Artigas, and the whole club team. I do not want to name anybody else because I always forget somebody, as happened the last time with Roberto Porro. So I wish to tell you that I am most thankful to the internal club team for their dedication to this work and how much we have learned. But all that would make no sense if we did not have you. I always look at the list of participants connection when I meet many friends. This democratic celebration in 3 languages on YouTube to all of you. So thank you very much for being here. I wanted to finish with a request, an invitation. The request is a bit YouTuber. Please strike like to this video. Go to YouTube and share it with friends, with colleagues who couldn't be here. Spread this information. What we did in these 5 webinars has been to bring the best available evidence to improve health with equity of children and women. As the video says, the vocation of CLAP is to care. And in order to care, we need people to know information better. And that is why we finish with the webinar on the Perinatal Information System, because we know that at the heart of decisions, there has to be knowledge that derives from the reality of each country and site with good information. And of course, the invitation, don't go yet. We are going to show you a video of CLAP. We have videos on YouTube, and it will be a joy for you to see it. And I know that for some of you it's lunchtime, for some tea time, and perhaps even are near breakfast yet. Thank you very much to you all, and we shall always be near you. Thank you very much. And let's see the CLAP video now.
Siempre fue un sueño trabajar en un lugar donde se puedan hacer cosas que marquen la vida de las personas. Y creo que el CLAP marca históricamente la vida de muchas mujeres y de muchos recién nacidos.
Durante estos 50 años, CLAP ha atravesado distintas etapas, acompañando hasta el presente las necesidades de la región para mejorar la salud de las mujeres, las madres y los recién nacidos.
Se fue migrando desde la investigación básica, la investigación esencial, a la investigación en salud pública y a la implementación de programas en salud pública.
En ese camino es muy importante la acción histórica del CLAP en el desarrollo de los materiales de capacitación, los instrumentos para la atención.
Durante un periodo de tiempo el CLAP se dedicó específicamente a hacer medicina basada en evidencia. Producíamos publicaciones para que le llegara a la gente en su propio idioma con las cosas más actuales.
Las investigaciones del CLAP permiten desarrollar buenas prácticas basadas en la evidencia que luego se trasladan a los países de la región de las Américas.
Lo que tratamos de hacer es encontrar a los docentes de medicina, de enfermería, de partería, para que sean los primeros que se entrenen.
CLAP ha expandido el CIP no solamente en términos geográficos, sino también se ha expandido a diferentes subgrupos, como por ejemplo recientemente se ha creado el CIP COVID-19.
La OPS siempre trabaja para lograr la salud universal. Este sueño no se alcanzará sin contemplar las necesidades de las mujeres, las embarazadas y los recién nacidos. Mediante la labor del CLAP, la OPS trabaja para que este sueño se haga realidad.
Duérmete mi sol, duérmete pedazo de mi corazón.